All right, welcome. Today, we're doing a deep clinical dive into the really complex world of wound infections. We're going to dissect how they show up, identify the microbial culprits behind them, and explore the strategies we use to fight back, whether it's in the operating room or dealing with unexpected trauma.
So, here's our battle plan. We'll start by getting the lay of the land, the clinical picture. Then we'll get into diagnostics, ID the usual suspects, and review our therapeutic arsenal. After that, we'll cover defense and prevention and wrap things up by looking at the very high stakes and some real-world cases.
Okay, first up, let's survey the battlefield. You see, wound infections aren't just one single thing. They show up across a huge spectrum, and that can make them incredibly challenging to manage.
And right away, you see this critical distinction. On one hand, you have acute infections. Think of these as a full frontal assault by a highly virulent organism. They're obvious: fever, a lot of pain, and even wound dehiscence, where the wound literally pulls apart. On the other hand, you have chronic infections, which can be much more like a subtle long-term siege, maybe just showing up as nagging pain or slightly off inflammatory markers.
Now, a prime and really serious example of a surgical site infection is the deep sternal wound infection, or DSWI. This is a nasty infection deep in the chest cavity, right behind the breastbone, that can happen after open heart surgery. It is a profound and very dangerous complication.
And these infections can present in all sorts of other ways. We see cellulitis, which is an infection of the skin itself. There's paronychia, an infection right around the nail. And then there's paneridium, an infection on the palm side of a finger. That last one is especially concerning because the anatomy of the hand is so tightly packed, it allows an infection to spread to deep structures like bone and tendons really fast.
So how do we find the enemy? Well, that brings us to diagnostics. To have any hope of effective treatment, you have to know exactly what organism you're fighting. Accurate diagnosis is, without a doubt, the cornerstone of good therapy.
We've got a whole diagnostic toolkit to be precise here. For a suspected DSWI, we go right to the source and culture fluid or tissue from the mediastinum. For something like cellulitis, a needle aspiration can get us the organism. We can even do quantitative cultures from biopsies to see just how heavy the infection is. And for speed, techniques like latex particle agglutination can give us a rapid ID on certain bacteria, giving us a critical head start.
All right, now that we know how to find them, let's meet the microbial antagonists, the usual suspects most often behind these infections.
What's really fascinating here is that the likely pathogen is almost entirely dictated by the clinical context, by the story of the wound. A post-op eye infection, you're thinking Staphylococcus aureus. But what if the eye injury was traumatic? Now you have to worry about environmental bugs like bacillus or clostridium. A chronic infection months after cataract surgery, that often points to a slow grower like Propionibacterium acnes.
So here's the crucial point. Identifying the bacterium is only step one. Step two, which is every bit as vital, is susceptibility testing. We have to figure out which specific antibiotics will actually work against that particular strain. It's essentially personalized medicine for microbial warfare.
And that brings us right to our arsenal. Armed with a precise diagnosis and all that susceptibility data, we can finally pick the right weapon for the job. Therapies designed for maximum impact. This all comes down to compatibility, which reminds me of a little microbiology humor. Why did the pathogen break up with the antibiotic? Because after the susceptibility test, they realized they just weren't compatible anymore. It's a joke, but honestly, that is the absolute core principle of targeted therapy.
And as you can see, treatment has to be incredibly specific. A post-op Staph aureus infection might need weeks of high-dose IV flucloxacillin. If it's a fungal infection with candida, you're using antifungals like fluconazole. And for those really complicated multidrug-resistant gram-negative bugs, we have to bring out the big guns like ceftazidime/avibactam. The drug, the dose, the duration, every single detail matters.
Of course, the best treatment is to not need any treatment at all. So let's shift to a proactive stance, prevention and control. The goal here is to stop the infection from ever getting a foothold in the first place. For a high-risk surgery like a sternotomy, a multi-pronged strategy is absolutely non-negotiable. This means giving antibiotics before the first cut, actively trying to get rid of any S. aureus the patient might be carrying before they even get to the OR, and keeping their blood sugar under tight control during and after the surgery to help their immune system function at its best.
But beyond these specific, high-tech protocols lies the absolute bedrock of all infection prevention: meticulous hand hygiene, proper wound care, and making sure any foreign material, like dirt or debris from an accident, is completely cleaned out. These are the fundamentals. They might seem simple, but they are absolutely critical.
Finally, let's bring this all home and talk about why this matters so much. We'll look at the severe consequences of a failed defense, and then we'll put our knowledge to the test with a couple of clinical cases.
The stakes are just incredibly high. An unchecked wound infection isn't just a local problem. It can invade bone, causing osteomyelitis. It can destroy the sternum, making it unstable. The bacteria can get into the bloodstream. That's bacteremia, which can then trigger sepsis, a life-threatening, body-wide inflammatory response that can kill you.
Okay, time to apply what we've learned. Here's a quick clinical vignette for you. A 45-year-old patient gets a deep sternal wound infection after cardiac surgery. Based on everything we've talked about, who is our prime suspect?
So, let's think back. As we covered, Staphylococcus aureus is a very common bug that just lives on our skin. When you do a massive procedure like a sternotomy, you're basically giving it a golden ticket to invade deep tissues. That's why it's the most frequently identified cause of DSWI.
So the correct answer is, of course, C, Staphylococcus aureus.
All right, ready for round two? This case tests our understanding of chronicity. Which of these symptoms is the least likely to be the only sign of a chronic, low-virulent surgical site infection?
Remember that big distinction we made right at the start? Those really obvious in-your-face signs like purulent discharge? That's pus. That screams acute, aggressive infection. Chronic infections are sneaky. They're subtle. So, purulent discharge is the odd one out here. And this all brings us to our final and most critical thought. We've laid out the clinical battlefield as it stands today, but pathogens are not standing still. They are constantly evolving, rapidly developing resistance to our best drugs. So the urgent question we're left with is this: how do our battle plans, our diagnostics, our therapies, our prevention, how do they need to adapt to stay ahead in this ongoing war? Thanks for joining this explainer.